The level of stroke severity as measured by the National Institutes of Health Stroke Scale Scoring System is 0, no stroke, 1 to 4, minor, 5 to 15 is moderate, 15 to 20 is a moderate to severe, and anything over 20 is considered severe. Clinical diagnosis of a stroke with the stroke scale is a symptomatic assessment tool that provides a quantitative measure of 11 areas of assessment for stroke-related neurological deficits. The scale was designed as a research tool to measure baseline data on patients in an acute stroke clinical trial. And now the scale is also so very widely used as a clinical assessment tool to evaluate the acuity of stroke patients and to determine appropriate treatment and to predict patient outcomes. The stroke scale has been shown to be a predictor of both short and long-term outcome of stroke patients. The scale is designed to be a simple but valid and reliable tool that can be administered at the bedside consistently by either physicians, nurses, or therapists. A trained observer rates the patient's ability to answer the questions and perform the activities. Ratings for each item are scored with a 0 as normal, and then there are some allowances made for untestable items. The assessment requires less than 10 minutes to complete, and the guidelines as of 2009 allow stroke patients with scores of less than 25 to be eligible to receive the TPA or the Activase. Improving cerebral perfusion. Interventions for stroke are determined by the type and the extent of the stroke. For an ischemic stroke, they're going to start 2 IV lines with non-dextrose isotonic saline. Put the patient in a supine with the head of bed low, continuously monitoring for any increase in intracranial pressure. Monitor for any signs and symptoms, knowing that the first sign of increased intracranial pressure is a declining level of consciousness or confusion. Look for symptoms of neurological changes or complications such as hyperglycemia, UTI, and pneumonia. The 2 major treatment modalities with acute ischemic stroke are systemic fibrinolytic therapy and endovascular interventions. IV systemic fibrinolytic therapy is also known as thrombolytic therapy. We've already been talking about TPA and RTPA and being the Activase as the plasminogen activator. Most important factor in deciding whether or not to give the TPA is going to be the time between the symptom onset and the time of treatment. Usually want it to be given between 1 and 3 hours with a maximum window of 4.5 hours. IV fibrinolytic therapy dissolves the cerebral artery occlusion and reestablishes blood flow to prevent cerebral infarction in an acute ischemic stroke patient. Activase, again, is the only drug approved for treatment of acute ischemic stroke. Most important factor in deciding whether or not to give it is going to be the time between onset and treatment. And that time was only extended in 2009 from 3 to 4.5 hours. Now that's going to be unless this patient falls into one of the 4 specific categories listed on the next slide. If the patient is presenting and is over the age of 80 or on current anticoagulation therapy with an INR or an international normalized ratio of less than or equal to 1.7. If the patient has a baseline stroke scale greater than 25, if the patient has a history of both stroke and diabetes, they are not eligible to be given the Activase. Now, to administer fibrinolytic therapy, the patient must sign a consent form. The dosage is going to be based on actual weight. There are protocols for mixing and administering and monitoring each patient following fibrinolytic therapy, also known as TPA or tissue plasminogen activator, thrombolytic therapy. We're all talking about the same thing. And these protocols are going to vary between facilities a little bit. Endovascular interventions. Intraarterial thrombolysis delivers fibrinolytic agents directly to the actual thrombus within 6 hours of the stroke's onset. Now, this is extremely beneficial for patients who arrived at the emergency department after that maximum 4.5-hour window to be eligible to receive the TPA. Now, if the patient's treatment begins within 8 hours of the onset, a mechanical embolectomy procedure may be done to remove the clot through a suction mechanism. Carotid artery angioplasty with stenting is a common practice for preventing and managing acute ischemic stroke patients. The placement of a carotid stent is done to open a blockage in the carotid artery, usually at the bifurcation into the internal and external carotid arteries. A radiologic procedure performed under moderate sedation has made angioplasty procedures a very safe procedure. Beforehand, a distal embolic protection device is going to be placed beyond the stenosis through a catheter that has been inserted into the femoral artery at the groin. This device then will catch any clots or debris that might break off during the angioplasty procedure itself. Post-procedural, before discharge, extensively educate the patient to report any of the following signs and symptoms to their cardiologist immediately. Severe headache, change in LOC or cognition, any new onset of confusion or drowsiness, so therefore the family members must also be educated. Muscle weakness or motor dysfunction, severe neck pain or swelling, hoarseness or difficulty swallowing due to nerve damage. Hemorrhagic stroke, when it is related to AVM or cerebral aneurysm, the goal of treatment is to embolize abnormal vessels or the aneurysm itself. The treatment of brain aneurysm or AVM depends on the size of the aneurysm, whether or not it has ruptured, where in the brain it is located, as well as the age and overall baseline health of the patient. Table 45.3 in your 8th edition, 47.3 in the 7th edition, Figure 45.4 in the 8th edition, Figure 47.4 in the 7th edition. A rare post-procedural complication can occur with the endovascular interventions. Hyperperfusion syndrome is possibly due to the result of impaired autoregulation from this long-term decreased cerebral perfusion pressure. Severe temporal headache, hypertension, seizure, and focal neurologic deficits may occur. This can be associated with intracranial bleeds and may occur within 1 hour post-op, up to 24 hours post-op, or even as long as a week later following the endovascular interventions. This concludes TIA and CVA for Module C. Thank you.